Good morning, everybody. This is an incredibly special day for everybody in the Department of Medicine, and especially if you're a gastroenterologist. It's a bit of a bittersweet time for us because we're remembering the recently passed Dr. Richard N. Redinger and all his contributions, including establishing this lectureship. He gave time, talent, and his treasure to the university. I'm going to read a little bit about him before we get going and before we introduce Dr. Nathan Liu. So Richard Redinger had been the chairman of the Department of Medicine longer than anybody in the history of the University of Louisville and also across the country. We think he might have been the second longest chair at 22 years in tenure. He had obtained his medical doctorate from the University of Ontario, so he's from Canada. And after medical residencies at Canada's Old Victoria Hospital in London, the University of Michigan, and Tufts University, he continued his subspecialty training in GI at Tufts University. When he was there in Boston, he secured the Department of Health Traveling Scholarship to Ontario for 3 additional years and served as a research fellow at Boston University under Dr. Donald Small, producing seminal papers defining the pathophysiology of lipid metabolism and gallstones, and that was his major research focus throughout his career. He was recruited to University of Louisville in 1981 to be the first academic chief of GI. Formerly, this was a small program that focused on education, and there was very little research until Dr. Redinger came to the Department of Medicine. He then continued his research and grew the Department of GI, including very importantly mentoring people to become other division chiefs at other prominent universities. He was eventually named the permanent department chair, having served as interim chair and division chief. I know what that's like for a while. And then in '92, he became the permanent department chair. During his chairmanship of 22 years, he tripled the size of the Department of Medicine, and he added signature programs which are flourishing today, and including the Envirome and signature programs in cardiology, GI, hepatology, transplant, infectious disease, and an NIH program project grant. So the NIH ranking under his chairmanship also improved dramatically, going from 0 to, I think we're at 48 today. I think it was 51 by the time Dr. Redinger retired. Even after retiring, he continued to come to our grand rounds. If you remember, he would sit in the front row, oftentimes with his wife, Arlene, at his side, and he always contributed to our department. Those that remember him, I do, he recruited me. He, as a person, he was kind, and he was tough, and he was an advocate for everyone. He was humble. I remember one day he had a cut on his head in clinic. It's because he fell off his roof when he was putting shingles on. So he was a can-do person who started from very humble roots, actually tobacco farming. He would tell you warm, wonderful stories. The other thing about him to remember today is how engaged he was in education. He valued education and teaching more than anything else, even though he grew the research part of our section. So he was very happy with his program directors achieving 100% board pass rate for the residents. So he also helped with endowed chairs, and under his chairmanship, we now have 15 endowed chairs. And again, with that, he and his wife established this lectureship to continue education, and we want to remember him in that very positive way. The second good thing about today is to talk about Dr. Nathan Liu. Dr. Nathan Liu actually got his degree in Emory, and that was BS in biology, and then went to the Medical College of Georgia. We got him at the University of Louisville for internship and residency. So most people in the audience remember Nathan. The things we remember about Nathan is you will not find someone with more energy. He's a prolific writer. He has dozens of publications. He liked to involve other fellow residents. He's a real team player. And we're happy to report after he finished his fellowship, he went down to the University of Florida to do an 18-month training in very specialized therapeutic GI work. And he's going to share that with us today. He will humbly not tell you, though, he's proudest of his wife, Haley, and their son and daughter, Barrett and Nora. So, Nathan, wow us with what you've learned down in Florida.
All right, thanks for having me. I'm really honored to be giving this lecture here. So we're going to discuss, all right. Okay. All right, let's see here. Okay, so we're going to be discussing third space endoscopy. I have no disclosures today. Objectives: understand the definition of third space endoscopy, the indications and procedural components of these procedures, POEM and GPOEM, and I'll explain what those are. And we're going to talk about the optical diagnosis of polyps and referral patterns for endoscopic therapy in the setting of EMR, ESD versus sending them to surgery. So what exactly is third space endoscopy? Just a quick review of the anatomy of the GI tract layers, and this is of the stomach, but almost all of the layers of the GI tract are similar. There's a mucosal layer, then there's a submucosa, which is full of all these blood vessels, and then you have your muscularis propria here, and then you have your adventitia here. So third space endoscopy is the utilization of the submucosal space for therapeutic purposes. So we use the third space, the submucosa, for treatment for achalasia, gastroparesis, and resection of benign and pre-malignant superficial polyps. So just a quick review of achalasia. It is the failed relaxation of the lower esophageal sphincter, loss of effective peristalsis. It can occur at any age. I've done a poem with Dr. Dragonoff for a 9-year-old here, and we've done them up until we had a 102-year-old a few months ago too. So it can affect equally any age. You have progressive degeneration of ganglion cells, which leads to progressive esophageal dilation, and then the increase in hypertrophy of the lower esophageal sphincter. What's awful is for these patients, they can't eat, they can't drink, they get pneumonia, they aspirate, they have megaesophagus, they can't lay flat, and basically they have a decreased quality of life. So this is an image. This is a 14-year-old we did a few weeks ago. She's got a megaesophagus here, and then this is the classic bird beak appearance. You can see the dilation here, and barely any contrast is slipping through. This is a gastric air bubble here. This is the CT esophagram of the poem after we did the procedure, and you can see there's just a large, this is a large esophageal diameter here. So what is the treatment for achalasia? There's surgical Heller myotomy. This has been traditionally the treatment of choice. What this is it's a laparoscopic surgery. They go from the outside, cut through the adventitia, and then they cut through the muscular fibers here to help release the GE junction. And then there's pneumatic dilation. This is where we go in and we open a balloon that's 30 millimeters in size, and we basically just try to tear the muscle from the inside. I never like doing this because this is basically completely blind. After you do the procedure, you go down and you look to see if there's a perforation. Hopefully not. And then the new procedure we do is POEM here, and Botox is only a temporary measure here. So I'm mainly going to discuss POEM here. So what POEM is it's called Preoral endoscopic myotomy. We take a scope, we make an incision in the mucosa, then we gain access to the submucosa here, and we actually tunnel through the submucosa all the way into the stomach. Then once we've made our tunnel, we come back in to where we made an entry point. About 3 centimeters below, we actually, from the inside, cut the muscle all the way down to the stomach. Once we cut all the way down to the stomach, we'll release the GE junction muscle, and then we'll come back up and close the area with clips. So let me just go over again. We make an entry, we tunnel down, and then we cut the muscle, and then we close the area up. So how do we do this? We have a bunch of different knives and tools. So this is an Irby hybrid knife. What's awesome about this knife is that this knife has a jet at the very end of it, and I actually have a pedal that's dedicated, and it's separate from the jet that we use on the scope. And as I'm in the submucosa, I can inject and open up the area for us to tunnel. This is called a dual J knife. This is a knife that has a jet function on the side of it. This one you have to have your tech use manual pressure to inject. What's nice is the knife is very small, so you can make fine movements with this knife. This one you can retract this knife, but the issue is in retroflexion. If you have to do anything in retroflexion, it's difficult to get this knife to come all the way out. This right here is an IT knife. This is a insulated tip knife. So this insulated cap, it doesn't conduct at all. So if you have the muscle on this side, you protect yourself, and you're only cutting with this knife here. This is a scissor type knife, and only the end of the scissors cuts. These sides here don't cut, so there's decreased risk of transmitting thermal energy with this scissor knife. So I'm going to show you the actual procedure itself. This is one we did a few months ago, and remember, it's entry, tunneling. Mainly the issue with this is treat any bleeding that you see. You do a myotomy, and then you do a closure. So here what I'm doing is I'm injecting a needle, and I'm injecting 8 cc's of methylene blue with normal saline. Once we've injected, I get a nice submucosal lift, and then what ends up happening is I take this out, and we go in with the knife. So this is the knife here. So this is the Irby hybrid knife, and I'm actually cutting down through here. This is the submucosal layer, and you can see all this connective tissue here. That was 2 blood vessels that we kind of cut through. And so I'm going to continue to extend this incision downwards. And so actually, if you look on the other side, there's muscle there, and if you cut through that, you'll be in the pericardium. So you kind of have to be very cautious here. The other thing that happens here is sometimes you can get bleeding around the edges here that you'll have to treat. So once I make a nice incision here, usually about 15 millimeters, I have a cap that's my surgical resection plane, and we slip into the tunnel here. Now what ends up happening is we're going to tunnel from the mid-esophagus all the way down into the stomach. So I'm using the knife here, and I'm just going to cut through this area down here. So I'm just coming around, and this is all connective tissue in the submucosa. The submucosa stains really nicely, so we use methylene blue, and that tells me where my planes are. Here, this is the white muscular fibers of the muscularis propria. We're going to end up cutting this at the very end. You don't want to cut through here at the very beginning of the procedure, because then the patient will get pneumomediastinum early on, and then we run into issues with ventilation. So here we're just going to keep cutting through. And what you have to be careful about here is you want to watch out for blood vessels here, and I'll show you how we treat that. So right there, I ended up injecting some methylene blue and saline using my actual needle with a dedicated pedal, and so that increases the amount of space I have to work with. The actual mucosa is on the left side here. If I cut too far to the left, I'll have a frank perforation, unfortunately. So you want to just kind of cut along the plane. And I actually use the muscle to actually guide me. And so I'm just kind of slowly kind of coming up around. Now this is sped up. This is around 2 times speed. So that's why my needle is kind of working kind of fast. So this is a coag grasper. This is a dedicated hemostasis device. And what I'm doing now is I'm basically cauterizing all these vessels that I see. And so actually this video, the myotomy's already been done. So this is adventitia here. And if you keep going through adventitia, you will get into the pericardium out here. And so what I'm doing is I'm actually grabbing the blood vessel and I'm moving it away from the adventitia so that I don't cause thermal injury there. And so I trace the blood vessels all the way up. And so you'll see that I'm going to work through. The main thing with third space is that there's a lot of bleeding that you have to be able to treat, and doing prophylactic bleeding is a requirement for this procedure. All right, I'm going to forward this through. Okay. So now what we're going to do is, this is the myotomy section. So this is actually us cutting through the muscular fibers here. So in the esophagus, you have circular fibers, and then you have longitudinal muscular fibers. So in the proximal esophagus, we're going to cut through all of the circular fibers first, and we're going to look for the longitudinal ones that are out here. And then I'm going to actually take this myotomy, cutting through the muscle all the way down into the stomach. And actually, when you get into the stomach, you can see serosa and peritoneum on the outside. So this is the closure. Once we've made the myotomy, which is the therapeutic part, we come back up to where we entered, and we use clips, and we want to well approximate both edges here. And so I'm just trying to get both of the edges in the very middle of the clip. And then I'm just going to end up clipping this tight. You almost want to have like a mohawk kind of appearance here with multiple clips. This is the very end, or the very beginning of the incision here. What I'm doing here is I'm getting the clip at the very proximal end. I don't want a doggy ear where the actual side of the incision comes back down. So that's the entire poem procedure, right? And so what do we do for follow-up? So POEM actually has a similar safety efficacy to Heller. What's actually nice about POEM is we actually make an incision through the entire muscle all the way down, whereas in Heller, all they're doing is cutting at the GE junction. So we actually have more of a myotomy than laparoscopic Heller. Patients are usually admitted overnight. Most of our patients go home the very next day. We get a CT esophagram just to make sure everything is closed, and then all patients get a manometry and pH study 3 to 6 months after the procedure. What we always tell patients before we do a POEM is the main issue is you get GERD afterwards. With achalasia, it's like a two-way street. Food can go down, but then acid reflux can now go up. And we have a clinical success rate of 91 to 95% for patients, and there's a 10% rate of GERD. It's amazing, because after POEM, these patients, just in a week or two, they're able to go on to a normal diet. They feel much better. They can lay down. They can sleep at night. Their quality of life is tremendously improved. And we can do these patients in non-surgical candidates as well, too. So now we'll switch gears. We'll talk about gastroparesis. So what we're doing here is this is called a G-POEM, and this procedure is very similar. What we're doing is we make an incision in the stomach, in the antrum, and then we tunnel down to the pylorus, and we cut the pyloric muscle down in hopes of relaxing everything so that food can pass through. So in gastroparesis patients, this has got a 4 out of 5 clinical response rate, and there's only a 5% adverse event rate, usually bleeding or abscess or ulcer, which is usually rare. And we actually, now that we have suturing, I suspect this adverse event rate will go down. So this is a video of a G-POEM. What's happening here is that's the duodenum over there. This is the pyloric channel here. And we can tell because it's almost got this cave-like shape to it. And so we don't want to stick this knife too far back this way, because then we'll have a perforation. So you want to stick the knife right there. I'm actually injecting to give myself a little bit of a cushion, and I'm going to cut the muscle all the way down. And so I'm just kind of splicing through as I'm coming across. And so you won't believe how thick this muscle is here. And so now we've cut the muscle all the way down here. And what we're doing is once we cut through, we want to make sure that I haven't missed any fibers through the area. So that's duodenum on this opposite side here. And so there's a few white fibers left. We're going to inject here, so that gives me a little bit more of a cushion, and then I'm going to cut through the side here. So now this is the opening. This is a novel suturing device called an X-Tack. And what it is it's actually with sutures. It's an endoscopic way of suturing. And what ends up happening is you have these tacks that the sutures are on top of. And using these tacks, we're able to actually suture through. I'll show you the end product here. Fast forward here. So the very end. So the very end here, you can see that this area is completely closed. This patient went home the same day. If they had had a surgical myotomy, this would have been a few days in the hospital. So third space, so now we're going to switch gears again. We're going to talk about endoscopic resection. So what this is basically removing pre-malignant lesions in the esophagus, stomach, small bowel, removing intramucosal adenocarcinoma in the setting of Barrett's, squamous cell carcinoma in the setting of the esophagus, also removing pre-malignant polyps in the colon. And basically, I want to talk to you guys about how endoscopic resection leads to decreased morbidity and mortality in patients. So this is just a quick overview of the NCCN guidelines. If you take a look here, this is what I want you guys to pay attention to. So a T1S lesion is carcinoma in situ, or also intramucosal carcinoma. This actually, even though it's a misnomer, even though it says carcinoma, intramucosal carcinoma, it only involves the lamina propria with no extension through the muscularis mucosa, meaning that this is a lesion we can endoscopically take out. Also, T1 is a tumor that invades the submucosa here. As you saw, we actually use the submucosa, we tunnel through. Sometimes if these cancers invade the submucosa and it's very superficial, we can remove it endoscopically and the patient doesn't need to go to surgery. So this is another thing just saying, for endoscopically removed malignant polyps, a malignant polyp is defined as one with cancer that invades through the muscularis mucosa into the submucosa. T1S is not considered a malignant polyp. So we end up getting a lot of referrals from the colorectal surgeons who have patients where the polyp pathology shows intramucosal carcinoma cannot rule out deeper invasion. And they actually send it to us to see if we can endoscopically take it out. A lot of times, usually about 4 out of 5 times, we're able to remove it without the patient needing to go to surgery. So this is the Paris classification. This is a way that we describe polyps. You have these polyps that are pedunculated. That means they're on a stalk. So what ends up happening is, even if there's cancer in the middle here, the stalk here is negative. And if we're able to remove the entire thing with negative margins, as long as there's no lymphovascular invasion, the patient doesn't need anything else. Most of the polyps that we see are these 1S lesions, and these are lesions that protrude into the lumen. And then we have these flat polyps where they basically like to kind of spread out rather than growing upwards. And I'll show you actually some videos of us taking these polyps out here. So this is the NICE classification. This is a way where we endoscopically look at polyps and we try to figure out what they are before we take them out. That way we can kind of know if this is a polyp that we can take out endoscopically, or if we need to go ahead and refer them to surgery. So this is your hyperplastic polyp. It's got this rounded type of pit pattern there. Usually these are smaller and they're kind of clear. This is your type 2 polyp. These are your tubular adenomas, tubular villus adenomas. These are not usually cancer. These are benign polyps. But if they continue to grow, they will turn into cancer. And so these have this kind of tubular type of structure. It almost looks like gyri in the brain. And these are your adenomas. And then if you look here, this is our white light, this is MBI. You can see how there's a dysmorphic type of pattern here. And there's loss of vascularity, it's amorphous, and this is going to be cancer. A little bit of feedback. So this is the JNET classification. So what ends up happening is sometimes with type 2, you have polyps that are not quite here. They're not quite here. They're in between. And so that's where JNET classification comes in. So here's another image. We have type 1. These are hyperplastic. This is going to be a tubular adenoma. But there's a new one called type 2B. And what this is basically you have some nice gyri in this area, but then it looks a little bit irregular, but not enough to call it this. So this is a type 2B lesion. Sometimes you end up finding cancer in this area here. And so this is a way to kind of classify if this is a lesion that might need what we call ESD. And I'll show you that what that is exactly. So this probably is the most important slide I want to share with you guys. So this was a systematic analysis of 200,000 patients where they had surgery for benign polyps. That means these are polyps that did not have any evidence of cancer. There were no evidence of invasion. The reasons for surgical referral were polyps in the right side. A lot of times you have a scope that's not straight. The scope doesn't want to do what you want it to do. And so in the right side, that's typically the location that happens. The median polyp size was 3 centimeters. And that's fairly larger size polyp, but not huge. And then the morphology is flat, meaning that it's difficult to just wrap a snare around it. So most of these patients had a laparoscopic surgery, so that means a lot of times that they're healthier patients. And this is the big thing. The complication rate was 24%. So 1 out of 4 patients had a complication. And the surgical complication rate was 17%. And that's within just 30 days. So this study pulled multiple studies into a meta-analysis. And this is only within 30 days, these complication rates. The complications were bleeding at the anastomosis, strictures, abscesses, leakage, ileus, DVTs. There is a 1-month mortality of 0.7%, and the average hospital day was 5 days. Median was 4 to 11 days. And I want to just stress that they did not even report readmission rates. So how do we compare it to when we do colonoscopy? So colon EMR has a 5 to 7% rate of bleeding, 1.4 to 1.5% of perforation, 5% of perforation with ESD, and there's a polyp recurrence rate of 16 to 20%. And I'll explain to you guys that even with this perforation rate and this bleeding rate, a lot of times we can fix this and we can decrease this 16 to 20%. This is old. We can show you that we can get this down to 5 to 10% with the methods that we do. And I always tell patients when we get referred for these large polyps that even if the polyp is removed and everything looks fantastic, we bring them back in 6 months, take a look at the scar. If there's any polyp left over, that is going to be a simple procedure where we remove the scar. And a lot of times we come back and there's no polyp left. But either way, we come back in 6 months, take a second look. If there's any polyp left, we'll take it off, And typically after the second colonoscopy, they're not going to have a problem. The cost saving per the patient is $7,000, and that does not include readmission post 30 days. Also, something that's not talked about a lot is that when surgeons, a lot of times when they remove parts of the colon, they actually go in and try to feel for the mass. They use tattoo to help tell what's going on, but a lot of times they actually feel for it. If you have a non-cancerous polyp that's flat, they actually can sometimes miss these things. So I won't delve into that, So I want to re-harp on this. This is a study that looked at 420 patients that had resection of a non-cancerous polyp. 28% had a major complication within 30 days. 11% had readmission within 30 days of resection. 6% needed to go back to the OR. 3% had an abscess that needed to be drained. 12% had a major wound disruption. 6% had a wound infection, and then 4% bled. So this 4% is pretty similar to colon post EMR bleeding here. So how do we take it out? What we do is when we have these larger polyps, we insert a needle into the submucosa. We inject and we raise the polyp up, and then we actually throw a snare around it. And the injection acts as a pillow cushion, so that when we remove the polyp, we don't touch the actual muscle here. So this is a technique that I learned here. It's called underwater EMR, and I think this technique is revolutionary. It came out back in 2012, and actually it was born from endoscopic ultrasound. What they found was when they put the ultrasound into the GI lumen and they injected a bunch of water, the muscle layer stays circular, but all of the submucosa and the mucosa actually floats into the lumen, but the muscle stays nice and circular. And so basically the idea is that when in the setting, if the lumen is filled with water, you actually do not need to inject. There's already a cushion there. So this isn't the biggest polyp, but this demonstrates what we're able to do here. And so this polyp ended up coming back as a tubular villus adenoma, and it's a 2B. And there's actually an error that I thought was a little bit concerning. But I'm wrapping the snare around it. I can see with the water exactly how the polyp looks, and I'm just going to kind of drape the snare over the polyp. Whenever you can remove a polyp in a single piece, that's always better if you can do that. It usually leads to better outcomes and decreased risk of recurrence. And so after one snare, this is what the resection site looks like here. And so to decrease the rate of actually bleeding and perforation, we throw clips on top of there. And actually using water, you can get the lumen to kind of come down nice and easily, and we're able to close the entire site here. I think this one ended up needing three clips. So sometimes, we have large polyps, we can't remove them in single piece. And so we can remove using the standard lift approach with a needle. So this is a polyp. I marked the edges of the polyp lesion with the end of my snare. And you can see all of this is polyp here. I first tried to do this underwater. I almost always like to do everything underwater. But unfortunately, because it's in the cecum, it does not want to lift the way it normally does. So what I'm doing here is I'm injecting a needle. I'm injecting methylene blue and saline using a needle, and I'm going to just kind of keep injecting and lift the entire polyp up here. And so I'm going to come around the side and lift, and I'm going to move in a systematic fashion from left to right. And I'm going to move up until the edges of the thermal marking as well too. Here I'm using my snare now. I've lifted, and I'm going to backhand the snare to grab around the side. And then we use heat here. And then that part of the polyp comes off. And now I can work from left to right. So you can imagine here that this polyp is around 6 to 7 centimeters big. We can remove much larger polyps than patients are being sent to surgery for. And so we remove polyps that are completely circumferential along the actual wall itself. These are blood vessels that we're seeing here. This is the connective tissue of the submucosa here. I'm using a coagulation grasper, and I'm just going to cauterize all of these blood vessels that I see. And this is going to actually prevent these patients from having a post-polypectomy bleed. And so I'm being real careful. That's the muscle down there. I'm pulling this coag grasper back, and this is the end product. And so now what I'm doing is I'm inspecting the edges of the margin site, and I want to make sure that there's no polyp tissue left over. So because I removed it piecemeal, I'm using, this is a APC, and I'm going to cauterize the actual margins. We find that sometimes recurrence happens because there's just a micro amount of polyp around the edge. Even though we think the polyp is gone, there's a little bit of polyp tissue left over. Studies have shown this can decrease the rate of recurrence from 15% all the way down to 5%. And so now I'm just going to move along the edge, and I'm just going to cauterize this entire area here. And so this patient is going to come back in 6 months, and we'll take a look at the site and make sure it's completely closed, or there's no polyp tissue left. Here I'm using this X-Tack, and I'm actually going to close the entire area up. And so I tried to suture it, but then I ended up needing clips as well too. And this is the final product at the end. And all this is going to, in 6 months, this will all be gone. But you can see that there's nothing here. This patient did not bleed, did not have a perforation. All right. So now I'll switch gears with Third Space. This is endoscopic submucosal dissection. So this was developed in Japan. They created this because they have tons of gastric cancer there, and they're able to actually remove all these cancers without resecting the stomach. What we do is we do thermal marking around the borders of the lesion, and then we use our knives to basically cut around the edges, and then we cut underneath and dissect the polyp off. And we remove this in one piece. This allows the pathologist to splice the whole area and make sure our lateral margins are clear and our deep margins are clear as well too. So this actually can remove T1S lesions, so intramucosal adenocarcinoma, and you can also take off very early submucosal lesions as well too. So the reason why you do this is because, if I remove this polyp in multiple pieces and the pathologist takes a look at it and one piece shows intramucosal adenocarcinoma, I can't be sure that I've completely taken this out and that there's no lymphovascular invasion because it's piecemeal. So even though the polyp's gone, this patient needs to go to surgery. And I've seen where we've done surgery and then there ends up being no polyp there, So this is a nice way where we can remove the polyp in one piece, and then a lot of times the patients know that this is a R0 resection and the polyp is completely gone. So this is the conventional method of doing ESD. We mark the area, we inject, and then I take a knife and I dissect underneath, and then we cut the polyp off in one piece. This is hybrid ESD. In this setting, this is very similar. We mark the areas, we cut underneath. Once I make a full circumferential incision, I cut through, and then I wrap a snare at the very, very end of it, and I actually use a snare to remove the rest of this. So I'm going to demonstrate that here. This is a large rectal polyp that we took out. We decided to do ESD here because this polyp is large and bulky. Whenever it's large and bulky, your MBI and your NICE classification that I showed you guys sometimes can give you false hope, and there can be cancer underneath. This is in the rectum. Obviously, if this is cancer, this is very morbid for the patient. So we want to actually take this out with ESD here. And so the thing about this lesion is that it's on the dependent portion. So that made it hard because it's difficult to lift. And here we're just cutting around the edges of the polyp. And I've made an incision here. And now I'm going to keep cutting around the polyp. And so now I'm increasing the submucosa there, and we continue cutting. So I make a circumferential incision here, and then I'll put a needle through the middle. I'm going to inject and lift this up, and then I'm going to wrap a snare around. And so this is the snare coming down. I wrap the snare around there, and I'm actually going to use the muscle as an anchor. And then I push my catheter forward, and then I tell the assistant to close the snare, and we actually remove this all in one piece. So this is a hybrid ESD. And so there's a little bit of bleeding here, and I have coagulation graspers. I'm just going to cauterize the area here, and you'll get a nice view of what the end product looks like. And then this is endoscopic suturing. We actually suture this area completely closed. And then this is the end product here. You can't even tell that anything came out. So we brought this patient back in 6 months. Site is completely gone. There was intramucosal adenocarcinoma, no lymphovascular proliferation. The lateral margins were negative. no deep invasion, and no tumor budding at all. And I think this patient was in their late 80s, so they wouldn't have been a great surgical candidate. All right, so this is called tunnel ESD. And what we're doing here is we use the principles of POEM. We make an incision in the distal part, in the proximal area, and then I tunnel under the lesion until I reach the other side. And then we make a lateral incision on both sides. And then I use a hemoclip or I tunnel underneath, and we basically resect the two sides that are left over. And then we remove the lesion in one piece. So this is an ESD that we did on I think the patient was 72 years old, had a history of oropharyngeal squamous cell carcinoma, and CT PET scan showed an area uptake in the mid-esophagus, had an outside EGD. Thank God they noticed this area. It's real slight. Biopsied it, came back as squamous cell carcinoma. Could not superficial squamous cell carcinoma could not exclude deeper invasion. We did an endoscopic ultrasound, didn't see any lymph nodes, and the PET scan was negative for Mets. So we decided to proceed with ESD here. If you look here, that right there, all of that is squamous cell carcinoma. Squamous cell is very scary, you cannot tell. This is Lugol solution. We use this to dye and see actually where it is. All this area that you see here, that's all squamous cell. So what we're doing here is I'm marking the area here, and then we're just going to tunnel underneath, and we did a 75% circumferential ESD. So if you see here, this is all submucosa and muscle underneath. This patient did really well. Lateral margins negative. Deep margins were negative as well too. The main thing we deal with after this is stricturing. So we give patients fluticasone, a fluticasone inhaler, and we actually ask them to swallow the steroid to coat the esophagus. We brought this patient back in 2 weeks. This is an image of the entire area resected here. And so we actually mount all these things as well too. So this is traction. This is where we basically use a clip. We tunnel underneath. We use a clip to grab the edge. We pull back on the actual polyp itself, and then we tunnel underneath. This makes the dissection quicker. We actually use dental floss sometimes. We also use sutures as well too. So we have all these different ways of closing these things when we do ESD. We use clips, we use over-the-scope clips, we use stents in the esophagus if there's any concern for a microperforation. We use X-Tack, and we use full-thickness endoscopic suturing as well too. So that's pretty much, so one last thing. So EMR, you remove this in multiple pieces a lot of times. This is not going to be as good of a sample for the pathologist as this right here. Even though these are two of the same products, obviously these are two very different things. So when is surgery more appropriate for patients? Sometimes we get in there and we see that there's investigation, the PIP pattern looks off, loss of vascularity, ulceration, these polyps that are non-granular, laterally spreading, they have a flat area. These a lot of times come back as cancer. So these two polyps got referred to us. They were biopsied as tubular villus adenoma, but we took one look and knew that these were cancer. If you see here that it's got this kind of calzone type of effect, and basically this suggests deep submucosal invasion here. What ends up happening is a lot of times people biopsy this area here because it looks nice, it's not bleeding, but this is not where the cancer is. So you want to biopsy where you think the highest grade of dysplasia is, which is in the very middle here. So both of these patients, we ended up stopping and we sent them to surgery. Actually, most of our referrals come from surgeons, and they really want us to take a look and make sure that the patient can't have an endoscopic outcome first. A lot of times what ends up happening is when you have a person that does ESD, we get a lot of referrals, and a lot of times if we can't do the ESD, then the surgeons get the referrals for that. So a lot of times both the surgeons and the endoscopists get more referrals. So even though it seems like we're kind of taking their patients away, a lot of times their numbers actually increase. And so this whole area of third space endoscopy and doing all these different things has bred this new field of what we call interventional gastroenterology. So basically what this is we do all these different procedures that we weren't doing 10 to 15 years ago. And some of the procedures we're doing is like portal pressure measurements, liver biopsies. We're using an ultrasound to assess this with ERCP. We're creating gastrojejunostomies in patients that have duodenal outlet obstruction, patients that have a Roux-en-Y gastric bypass that need an ERCP. We're able to place stents, get into the remnant stomach and do a straightforward ERCP. We're able to treat Zinker's diverticulotomy. Usually these patients stay one day, go home the next day. This right here is a 15-minute procedure for us. We get a lot of ENT referrals for this. Patients that have perforations, we're able to fix with stents. A lot of times I get referrals for luminal defects, intracutaneous fistulas that need to be closed. Patients that have had surgeries gone wrong, that where they have leaks, we get sent those. We do spirus enteroscopy. This is a whole new field of bariatrics. We're doing endoscopic sleeves. We're doing intragastric balloons. We're doing minimal ablation type of therapy for Barrett's esophagus to prevent these from turning into cancer. And then this whole field of third space endoscopy that I just kind of talked to you guys about. All of this has just come out within the last 10 to 15 years. So it's really exciting to kind of see what new things are on the horizon out there. So once again, I just want to give a thanks. This is my family, this is my wife and my kids, and this is my GI fellowship. And I had a great time at Louisville. I'm really excited to be coming back to you guys. So, and that's it. So I'll take questions now.
Well, thank you, Dr. Lou. That was outstanding. Dr. Krueger, would you like to lead us off here?
Yeah, I mean, I think everybody can see how Nathan can show you that advanced technologies in the field of gastroenterology really blur the lines between what is a surgeon versus what is a gastroenterologist. And as he mentioned, we are not really stealing patients. We're just doing advanced approaches to get the best outcomes for our patients. And so this is what therapeutic endoscopy is like today. And you can see why it would take lots of training and dedication. Some of these procedures take several hours. He didn't mention that, but the outcome for the patient is so much better than going to surgery. So we are so happy to have this available to us. Jewish Hospital is going to spend a good bit of money getting the equipment that Nathan needs to be able to do these procedures. So, and it was interesting the way you present too, Nathan. I think everybody can follow it. Sometimes they won't follow surgery if they don't do surgery, but with your slides and the videos, I think that was just really great. So I know there are a few people that want to ask questions. If you have any to ask or you want to say anything to Nathan, either raise your hand or we'll look in the chat.
Yeah, as Dr. Krueger mentioned, if you have any questions, you can unmute and ask, or if you want to type it in the chat area, I'll see it and I can read it for Dr. Lou. Or maybe he gave such a, oh, I'm sorry, as I say, or maybe he gave such a great presentation, he covered all the bases. It was like Dr. Omer, go ahead.
Hey, Nathan, excellent presentation.
Hey, thank you.
You'll be here soon. So, point for achalasia, the surgical versus in treatment. One of the sticky, like GERD, post-point GERD. You said it's about 10% in your experience, but recent study, long-term, no difference whether it's Heller or POEM, like a year or, or 2 years out. But that POEM has significantly assessed 50% GERD. So how do you square that with your, experience about 10%?
Yeah, so actually it depends on which studies you're looking at. And also, if they actually did the pH ambulatory, a lot of patients will complain of GERD, but then we actually do the pH test and we find out that there isn't actually as much GERD as the patient thinks. Or sometimes we actually do the pH test, and even though the patient doesn't have GERD, we find out that they do have GERD and we give them PPI. There are patients that a lot of times they're doing Heller myotomy, and they're also doing a Nissen fundoplication at the same time. So the poems that are very difficult are patients that end up doing a Heller myotomy. They have an incomplete myotomy because the surgeon doesn't want to go too deep and cut all the muscle because they don't want to have a mucosal defect. And then they do a Nissen, and then they get referred to us 6 to 12 months later for a poem. When you do a poem in a patient that has a Nissen, it's very difficult because it's wrapped, and all of a sudden our planes are very difficult to kind of tell. So, and I agree with you. I think the 10% that it actually is kind of low. So it depends on which studies you're looking at. We have a huge poem research trial here that we're looking at, and I can tell you the patients really do improve, and a lot of times they will respond to the PPI really well. So it is a 10% risk, but we also have new procedures now like TIF, where we can actually go and fix this or help them with acid reflux if they had that problem. So we can fix it. So.
Thank you.
Yep.
Nathan, I had a gastroparesis question because you mentioned
Okay.
pretty good outcomes
Yeah.
with doing the pyloric muscle cut. Are you first having them have endoflip in order to predict, or Botox in order to predict, and how do you combine that?
So endoflip is so brand new. There's not a lot of studies with it. So that's going to be an area of huge investigation, and that's something that we can do. Botox, the thing about Botox is if you saw the video, the muscle is so thick. It's so thick. And I can tell you doing these procedures, some people the muscle is paper thin, and some people it's so thick. There's no way you're going to get your needle all the way through. And a lot of times what ends up happening is most of the Botox is submucosal injection. You're not actually getting it inside. If you look at the studies, everyone has different outcomes, to be honest, depending on what they're looking at to define a clinical success rate. The actual procedure success rate is 95 to 100%, but some people report 60, some people report 80% clinical success. Some people only do this on post-surgical gastroparesis. The study I found, it was in all comers. It was, I think, 250 patients, and they had an 80% success rate. So it will be interesting, since this procedure is so new, that as we do more of these, to see if other people can replicate these outcomes.
Right. I mean, for the audience listening, we have EndoFlip here, and we're doing it a lot. But to Nathan's point, we don't know how it will apply or help predict who might benefit from a pyloric procedure versus a gastric stimulator. And so we have a lot of gastroparesis patients. So we've got the ability then, with your abilities, to be able to set up studies and figure out what is the better way to go. So I think this is great.
All right, Dr. Liu, we have a question in the chat area from Rosemary Usef, who's our Chief of Nephrology and Hypertension. And
I remember Dr. Usef from when I was an intern. Yep.
Yeah,
awesome.
she is back. And,
yes, I get to torture lots of people when they're
well, Dr. Usef, do you want to ask your question, or I can read it? Whatever.
Oh no, I can ask it. You know, Nathan, we have a lot of patients who have to lose weight before they're eligible for a kidney transplant. We have a BMI cutoff of 35. So I was wondering how successful the endoscopic gastric sleeve was.
Yeah. So the endoscopic sleeve and the balloon are fantastic. So the balloon that we do, we literally take a scope, we go into the stomach, we blow a large volume filling balloon, about 500 cc's in there. And actually, patients lose 40 to 50 pounds in 6 months. It is not permanent. In 6 months, we take the balloon out, and it's a really nice way for patients that are not surgical candidates to lose weight. The other thing we can do is endoscopic sleeve. So right now we're doing a lot of sleeves for patients that either don't want to have surgery or not surgical candidates. And in these patients, actually, a lot of times they'll lose 30 to 40 pounds in 3 to 4 months. And the nice thing about endoscopic sleeve is that they don't get reflux as much as in surgical vertical sleeve because we preserve the fundus. So they still have a pouch where food can go inside. And what's nice is if we have issues where they're not responding as well, we can go in there, add another suture in there if we need to. So if you have patients that surgery does not want to touch, as long as there's not an issue with an anatomical issue or they're cirrhotic, we can do endoscopic sleeves on these patients and help them lose that weight. So hope that answers your question. Yep.
Yeah, that's great. I mean, like I said, a lot of these are ESRD patients. They have to be a BMI of 35 or less before they can get their transplant. So this will be great.
Yeah.
Dr. Liu, that was a fantastic talk. I got a quick question here. In passing, kind of dovetailing into Dr. Youssef's question, the GLP-1 agonist, I think they have pretty significant weight loss, and I don't know the percent, but that might be worth, looking into for weight loss till Dr. Liu gets here and gets going. So my question was, how do you deal with the reimbursement part? I mean, these procedures, they take hours, they take a lot of equipment and insurances.
That is a 2-hour lecture, actually, on reimbursement. And what ends up happening is...
I guess in Florida, they have worked out a way where they actually get reimbursed.
So for a poem, it is equivalent to a Heller myotomy. So actually, we get reimbursed the same as much as a Heller because that's an equivalent procedure. So here, the endoscopy.
How about for a TIF? How do you code for that? Do you get
TIF actually does have its own procedural code, and it's worth 7 RVUs. ESD, you have to reimburse it as an unlisted procedure, and you actually bill by the hour. So each hour, I think, is worth 7 to 8 RVUs. So you bill.
Okay, so you got it worked out.
Yeah, you have. Well, so when I get there, I'll have to work it out with the billers. But yes, we do get reimbursed for these. And they're working on dedicated CPT codes, but there's unlisted procedure codes for every lumen of the GI tract.
Yeah, otherwise it's going to be unsustainable unless you figured it out. And what's your model there? I mean, this is, at the interface of minimally invasive surgery and GI. So do you have a surgeon working with you?
Oh, yeah. Or? We work with colorectal surgery. We work with MIS. We work with the general surgeons. We're very collegial. Most of our colon ESDs referrals are from surgeons where a GI doctor has referred them to surgery, and then they end up sending the patient to us to take a look at first. We get tons of referrals from GI doctors in Georgia. We did an ESD the other day from someone all the way from New York City. So we get referrals from all over. Every day I'm doing 2 or 3 colon EMRs that were referred from other GI doctors or from a surgeon.
And you've done poem on somebody from Louisville, Kentucky.
That's correct. Yep, we had a referral from up there.
Great, we're very excited. Thank you.
All right. Any more questions for Dr. Liu? Then feel free. You can again unmute and ask, or if you want to type something in the chat area, we just got a minute or two here before we have to wrap up. So.
Well, Nathan, I think you'll also achieve here. We've got some really nice young, dedicated surgeons as well that are early career, mid-career. Fareed Katie, Prajesh Phillips, and some ENT surgeons. I'm sure they get involved also with the Zinkers and things. So I think that's going to be very good for collaborative work with our junior surgical faculty. And
absolutely,
yeah.
All right. Well, thank you, Dr. Liu. And I'll make a quick mention because I've almost forgot. But you may remember. I don't know if it was we were doing it while you were here, but you may remember we began a tradition under Dr. Roman to give a little gift to our grand round speakers, and today's especially poignant, being the Arlene and Richard Redinger lecture. So you will be receiving your very own Louisville Slugger bat. Commemorative bat,
Thank you.
and it'll be inscribed with your name and the 2021 Richard Redinger lecture. So congratulations, and
so much.
Echo everybody's feelings that we can't wait to have you come back.
All right, thank you so much. I
Have you
appreciate
be
your time.
back.
Very honored to be back and giving this lecture. Thank you.
Thank you,
Thanks,
and Dr.
Nathan.
All right, thank you.
All right, everybody, and again, thank you, Dr. Liu, for an outstanding talk, and we will be back next week. Actually, we will be discussing nephrology, and Dr. UofL has invited a wonderful guest, John Arthur of the University of Arkansas, who's the chief of nephrology at the University of Arkansas. So we're looking forward to that, and that's next week. It'll be 8 a.m. next Thursday, December 9th, and we hope to have everybody back and to see us. And thank you again, Dr. Liu, and we'll see you in a few weeks.
All right, see you guys soon. All right.
All right, thanks so much.
Bye.